revisit. So this is now week 3, and what is due this week, of course, was, if you haven't done so already, your discussion 2 and homework 2 and quiz 2. That is due today. So by closing of business, I'll check. And of course, if there's statute of limitations for every day you're late, the grade gets cut off, except for quizzes. Quizzes, I designed it in a way that all you have to do is, like, let's say I scored an 80 and on my first pass. Try it again and try it again and to score a 100. And hint, hint, when you try to make a midterm and or a final exam, the one way to practice it is actually take little mini quizzes on every chapter. And you can also do that via quizzes, which are mandatory, but you can also look at the chapters as well. Now, I have an old lecture here, so I'll, of course, post this mini lecture, but I also have an old lecture here as well, which should correspond with your textbook, which is here. And the textbook in question, just to remind you guys, it's this one. It's not the red one. It's the blue one. That's the textbook, because the red one is the procedures, and that has the step-by-step procedures. Or is it backwards? Let me see. Oh, it looks like the blue one is the procedures. So if you look at, or is it procedures? And if you look at, let's see, table of contents. Oh, my baby's awake. Hey, Belle, can you take baby to mommy? All right. So if you look at, this is history taking. Okay. So if you look at the blue book, there's all these lovely questions you could practice for. And if you're one of those people who say, "Oh, I'm a bad test taker," that's not a real thing. If you're bad at exams, or you typically didn't score high in your SATs or ACTs, it's because you simply didn't prepare correctly. Bad test taking scores is about poor preparation. And when you think about it, my midterm and my final are multiple choice examinations. But when you read your book and do your notes and watch videos, that's not actually taking the test and practicing the test. So that's like, a prize fighter, somebody who's a boxer. Oh, I watched the videos and I punched the punching bag. But the prize fighter has to actually go in the ring with another human being and punch it out every day. And that's what you should be doing with these quizzes. That's what you should be doing with all these exercises. And then you go down the exercises based on what we're doing that week. And actually, I believe some of the homework that I've signed is actually cut and paste from this stuff. So what we're doing today is review of patient interview and patient history, right? You can even take some of these short answers and make them multiple choice. Like, what are the 6 C's of charting, right? We'll be talking, and if you had MED140 before, great. But if you haven't, it's a nice introduction. Name the 7 kinds of standard information. Do you think you can, what does SOAP mean? The acronym SOAP, S-O-A-P. Do you think you can make this into a multiple choice examination? I believe so. And that's a good utilization of the blue textbook. Now, the red textbook, that's the one where, of course, it has the chapters and stuff in it. And let's go to chapter 36, table of contents. Let's go. Now, the way they did it here is they did it like units. So you have to like open and close these little arrows to figure out where exactly you are. So applied anatomy, physiology, nope, that's not it. It's like unit 7, diagnostics. I think it's 8 with therapeutics. It's hard to navigate sometimes. 45. Here you go, 36. So if you look at the textbook itself, it always opens up. And this week's topic is patient interview and history. And again, what's important about patient interview and history regarding lab tests? What does that have? What does that have to do? Well, it goes. What does that have to do with what we're doing? Well, many times you'll be the one to actually not do the whole interview in history, but many times you'll be the one doing the intake where you have new patients and you have to get their story. So the patient interview in history is really important. So all the chapters, well, most of the chapters open up with something like this, with some stock photo. And Peter Smith, 73-year-old male with mild type 2 diabetes. That means most likely is controlled. I don't know why they use the term mild here. The term would be either controlled or uncontrolled diabetes. And if it's controlled, that means his A1C, which is glycosylated hemoglobin, and his blood sugar. Typically, we look at FBS, also known as FBG, which is fasting blood sugar or fasting blood glucose, is most likely controlled and most likely controlled with meds. He states that he's feeling very anxious and fatigued. So that goes, and having difficulty eating and sleeping. So right here, that's his chief complaint. Now, you can't use the words anxiety state, right? Because that's an actual diagnosis. But you could say, quote, feeling anxious and tired or fatigued, right? Now, these associated symptoms, difficulty eating and sleeping, that would also be part of his history of present illness. What are the things that are related to the chief complaint of what I hear? Now, the HPI, or history of present illness, relates to the chief complaint because it's like he may have maybe chest pain, or maybe he has gout, or he's already 73. Odds are he has some sort of arthritis or something musculoskeletal joint related. Now, if you know, like if all these other problems do not necessarily match up to his chief complaint, so that'll be elsewhere in the history. And he arrives to the clinic with his wife. During the patient interview, he states that he wakes up in the middle of the night, and it goes almost nightly, right? And then you have to ask, when did that all start? Many nights where he can't even fall asleep, which is common for age 73. I'm only in my 50s, and I have these same complaints. But here is also significant. He lost 8 pounds in the last month. Well, because maybe he was working out. But typically, significant weight loss is anything more than 1.2 pounds per week. So in the last 4 weeks to lose 8 pounds, that's considered significant weight loss. And if he's working out, that's great, but it looks like there's something else going on. And his symptoms started 6 months ago, right? So, but what happened 6 months ago? His son died. So now, getting the whole history, it doesn't look like maybe a thyroid problem or low testosterone or just old age. There's something going on here. So the plan he needs to go see psychiatry, because we're looking at other things, because at first it looked like, oh, maybe his diabetes is not being controlled, maybe it's something else. But now we see that this is a potential psychiatric issue. So that's what helps us in the patient interview and patient history. And many of these things, like let's say, for example, he was coming in, coming in new to us. Now it paints a very different different picture. And if you could see, they will do Dr. Buckwalter, which is the attending who saw Mr. Smith. They'll see that we're going to do a sleep study, because maybe it might be a sleep or a neurologic problem, right? But when you're looking at this, because his son died and all these symptoms, we also have to talk to psychiatry as well. What else we're going to also have to do? Since his advanced age, we got to look at his diabetes. I'm going to look at that too. I'm also going to be looking at his gastrointestinal tract because he also had difficulty eating. And remember, all of this stuff you put in word for word regarding the history. But when we start talking about diagnoses, fatigue, could have potential anxiety. Difficulty eating is dysphagia or dyspepsia, and difficulty sleeping is insomnia. So if you recall your medical terminology, you got to use your medical terminology powers. Now, if we're looking at this case, right, and we're looking at it from MED140 exam perspective, what questions could I ask? All the stuff that we went through. I could ask, oh, in this patient, and I'll copy and paste this, put it on an exam. Oh, in this patient, what is the chief complaint? And the chief complaint was what? I'm feeling anxious and I'm fatigued, right? What's another term for his difficulty eating? Dysphagia, dyspepsia. How are we going to code that the fact he can't sleep? Well, he can't sleep. That's called insomnia, right? Because remember, when you're doing ICD-10 coding for billing purposes, you can try to you'll look up difficulty eating. Yeah, it'll eventually give it to you, but it's much faster if you know your medical terms, right? And then we could see here definitely somewhere in the plan, we should not only do a sleep study with neurology. I think we should also call psychiatry as well. So you could see the merit of how a good screening or how a good history can be taken. Now, of course, read through the patient rights and responsibility and privacy parts. The part of the American Hospital Association's Patients' Bill of Rights. And that is the form that, you know, when you go to the doctors or hospital, that's the form that no one ever reads and they just sign at the bottom. Well, you should not only sign it, you should read it, because there's some really important things here. And a lot of it has to do with HIPAA, and a lot of it is how we communicate information. And one of those things that how we communicate information is, right, patients need to know that you have the right to refuse treatment. Okay, they need to know that HIPAA laws apply. I cannot speak to people for 3 reasons. Well, I have to speak to people for 3 reasons, and HIPAA assures privacy. One reason is clinical. Let's say, for example, you're assigned to Mr. Smith, our case. Then I can talk to you. If you're another nurse in the ward that's not assigned to Mr. Smith, can I speak to you? I cannot, because we are assigned clinically to that patient, and you cannot talk about that patient, even refer to that patient, other than other clinical personnel. Another person that you have to speak to regarding Mr. Smith is, let's say the billing department, right, has questions. So that's payment. So you have to speak to the billing department, and they'll ask you, oh, what was the diagnosis? What was the official diagnosis? Does he have a sleep disorder? I have to answer those questions so that the billing department can do their job. So clinical, billing, and then the last part is just simple logistics, organization of my patients. If the ward nurse asks me, hey, goes, is Mr. Smith diabetic? Right? I'll ask why. And then she'll tell me, oh, well, we're organizing all our diabetic patients in the database or on the charts. Then yes, I have to answer, because it's part of the logistics. It's part of the organization of the hospital, right? And so those are the only 3 times that you can release information. 1, clinically. 2, billing or money-wise, right? And only talking to the billing, right? And 3, just the overall logistics and organization. That's the only time you share information. Other than that, like, let's say Mr. Smith is giving you a hard time. You can't talk, like, everyone talks in the ward and everyone talks in the hospital, but you got to keep that in private. And of course, it's interesting. There's funny stories and there's annoying stories that you share as colleagues. But honestly, professionally, I actually just had a conversation with my wife. She works for Inova Health Group, and she has to remind her colleagues that, hey, um, uh, we're being recorded, and sometimes they complain online and they forget. And be very careful, because you know and overall, just act like you're being recorded all the time. Act by the rules. Isabella, your mom is calling you. Sorry about that. It's the disadvantages of working from home. So of course there's HIPAA. Read through that, because that's a really big topic on your what do you call that, on your AMA, CCMA, those exams, your registry exams. And I highly suggest you take those registry exams. And if you want a quick informal review, come see me. I can get you some of the material that I've helped others, and that's the actual material that 2 years ago I took to take the exam as well. So I'm also telling you about this from a first-person perspective of what's kind of going to be on the exams. Now, if you go through this, your interviewing skills, actually genuinely listening. I had a student last term who used to just stare at the clipboard and just write all the time. And she was actually removed from her externship site because they stated that she was being rude. Well, she wasn't being rude. She wasn't effectively listening. And remember your mirroring technique. You got to nod your head. You have to actually show that that you're listening. And one technique is restatement or mirroring. You can put it back to the patient. For example, if we were talking to Mr. Smith, and he goes, he goes, did you mention dizziness or anything else like that? And he goes, you had difficulty eating and sleeping. Did you have any dizziness? Do you see what I'm doing? Right? I'm putting it back on him, and he'll be like, oh, no. And then that will be what? Restatement. Now, nonverbal clues and body language. Remember, those of you who have children know this very, very well, because your patient, remember, they could be scared. They probably are very scared. So take into account nonverbal clues. And when you're doing your head-to-toe examination, or even just helping them get onto the table, see how they react to being touched. See how they react when the doctor is doing their head-to-toe physical examination. There's something called guarding. So if something really hurts, you'll kind of use your arms and your body to protect it, that side, even though the patient might say, no, I'm just ticklish. And you could also see the wrinkles in their forehead. That's called grimacing. When they bite down a little bit and they have the wrinkles on their forehead, that means that there's pain wherever you touched. Okay. And remember, pain is highly subjective. It's different from person to person. So they may be exaggerating it or they may be denying it. So you watching their nonverbal cues is really important. Use a broad-based knowledge base. That means it goes, you need to know about your patient before your patient comes in. And I know that's best case scenario. It's hard sometimes trying to read the chart right before we talk to the patient. But like I told you, my wife works for Inova. One of the things that the call center has to do before they speak to the patient, when they look up the patient information, they put the patient on hold, and the administrator has to read a little bit about their chart and practice their name a little bit and know who their wives are, who their family is, so that they have some connection in a short period of time, right? And it also gives you the big picture of what's going on. So if you read only a little bit of Mr. Smith's case, you wouldn't have known about his son. And if you don't know about his son, then we'll keep on treating him as like a neurologic, or we'll be giving him medication just to sleep. And that happens every day in the hospital, where doctors, nurses, other medical professionals, they don't know the whole story. And if you don't know the whole story, you know, you tend to do the poor management. And remember SOAP. Let's write that down. If you remember SOAP, S is the subjective. That's what we're talking about, which is, let's make this bigger. S is the subjective. That's what we're talking about, history, right? O is the objective, and that's the physical examination and any other labs to confirm the history, right? And of course, history, what do we now know? We now know chief complaint, history of present illness. We haven't talked about the other histories, which is past medical history, family history, social history, right? There's a whole bunch of things. But now you could see how getting the story and getting then having the laboratories and the physical examination to confirm it. What do we have now? A is the diagnosis. And if you recall, diagnosis from your medical terminology is state or condition of complete or thorough knowledge. And what is the complete or thorough knowledge? It's all the histories, all the PEs, all the labs done by all the people, all the professionals. And what do we have now? Then we have a good plan. Now, if the plan doesn't work, my patient isn't getting better, guess what we do? We go back to the beginning. But many people just go, the plan isn't working. Let me just change the plan. Let me give them new meds. And that's why there are millions of patients out there who don't get help. They just keep on going in circles and circles and circles. And a good clinician will always go back to the story and then work their way back down. Because what is the diagnosis? Is the state or condition of complete or thorough knowledge. If the state or condition of complete or thorough knowledge is wrong, what's also going to be wrong? The plan. And will your patient get better? No, they won't. And that's the reason why you keep on changing doctors or whatever, because many people, and also we'll talk about it another time, many times the plan gets messed up because either the patient doesn't listen to it or the patient is demanding something else. And as a business person, that's another thing that you have to think about as a clinician is you got to give them what they want. I actually had a conversation with my mother, and my mother was a neuropsychiatrist for over 45 years in New York City. And we were talking about how we just give in to patients. Like when they come in, they pay their $20 copay, and for the $55-$65 or so that we charge them for a 30-minute office visit, they want something in return, right? Even though, like, let's say, here's a classic example. Oh, I'm having a cough, doc. I need some antibiotics. I don't know that you need antibiotics. I haven't went through my entire history or my physical examination, nor do the labs dictate that you need those medications. You need a antibiotic, but the patient is insistent. My sister Sally got it and she got better in a day. I want some antibiotics. So what will most doctors do? They give in and they give it to them. And then what happens? It ruins the plan. And you're giving patient medication that they don't need. Because part and parcel of what we do is try to educate our patient on why I'm not giving you the antibiotics. And by the way, all these antibiotics just given, willy-nilly, that's what causes MRSA and VRSA, multi-resistant strain, Staphylococcus aureus, vancomycin-resistant Staphylococcus aureus, right? Methicillin-resistant Staphylococcus aureus, because we keep on giving antibiotics where we don't need to. So remember, there's also the money aspect of it all. Now, you may be wondering, like, they never do half of this for me. Well, again, back to the money aspect of, remember, you have to also pay attention to the financial aspect of running a business. If we did every single thing in the physical examination, every single thing in the history, a lot of the patients will get bored. A lot of patients will be upset. Like, I have a cough. Can't you just give me the medication? right? So over time, just like driving, you do shortcuts. And then after you do shortcuts, right, it's a slippery slope. And then how many of you have ever been to the doctor's office where they just look at you and they, oh, here you go, here's some antibiotics. I've been a victim of that several times, and I've also been a purveyor of that, unfortunately, when I was practicing. But my job here is to show you in a perfect world how we're supposed to get all of this done, right? Again, some of this successful stuff is some of the stuff that we were talking about, right? Have a good plan. We already talked about that, right? Do a little research, read a little bit, know how to pronounce your patient's name. And if you don't know, ask, right? Remember, in a short period of time, you have to develop a rapport with your patient, because after this history taking, we're probably going to do some labs, and I have to probably poke you with a needle in a place that you won't want me poking you with a needle. So having a good interview skill and having a good people skills, and this takes practice, right? Just like taking tests, it takes practice, right? Because you're trying to make the patient feel with ease. You're talking about private things, right? You're trying to give respect for a person that you don't even know, right? And this one, number 7, do not talk about diagnosis, because are you in a state of complete or thorough knowledge? No, you are not. And legally, if you're in my MED140 class, the only person who could speak to the patient regarding diagnosis is the physician in charge, or the NP in charge, or the osteopath in charge. Whoever is in charge fully of the patient. So if you know they have cancer, keep it to yourself. Oh, I goes, how's my biopsy? Did it come back positive? I think it's positive. Even though you know, you say what? I goes, I will make sure the doctor gets the message that you really need to know the diagnosis. And employ your doctor, like, hey, is someone going to tell her about the biopsy? Right? And of course, what we talked about, formulate what the physical, and reading the entire, not physical, the entire history, it formulates the big picture. And you could see from the case that we talked about earlier, you could see how easily the big picture can be missed. Because when did he mention the sun? It was at the end of the interview. Okay. So those are some really important traits. And one thing that this chart right here in chapter 36, or table 36.1, look at these things. Look at the ones up top versus the ones on the bottom. Be careful of closed-ended questions. Those are questions that are yes and no. We go through a lot of training, because if you say, hey, do you have a cough? What's the patient going to say? Like, oh, I coughed once yesterday. Yeah, I think so. You're like putting ideas in their head. The best is, what else can you tell me about? Anything else going on? Right? You got to leave it open, because if you say, do you have a cough? Do you have a fever? Or do you feel dizzy? This is the one thing that the American Psychiatric Association is really big on, because they're very, very good at psychotherapy. They're very, very good at the history. And in the early 2000s, there were a lot of psychiatrists and psychologists who were putting ideas in people's heads because of closed-ended questions like, have you ever been touched inappropriately by your father? And then you start thinking, hey, my dad hit me a couple times. And then they start connecting dots that shouldn't be connected. I think I've been abused. And then it gives them reasons like, oh, maybe I should be on Xanax and all these other medications that I don't need to be on. These people weren't abused. The clinician started putting that in their head, right? Instead of, a better question was, how do you feel about your childhood? How do you feel about your father? How do you feel about your mother or the people who raised you? Open, right? No, yes or no. Have a hypothetical, right? What would happen if you had chest pain? What would happen if this happened? And it gives, because giving a hypothetical question actually gives an example of the state of which your patient is in, especially like something like chest pain. Like, it goes, oh, I would sit down, I would do this. Now that gives you what things the patient does to make the pain go away. And actually, that's part and parcel about how to ask your patient about pain. And the mnemonic is called PQRST. So let's look at PQRST. So that was the first one of the PQRST, right? P, palliative or provocative factors. So you complaining of chest pain, Mr. Smith. Can you tell me about a time that it made it better? Can you tell me about a time where it made it worse? Oh, well, when I mow the lawn, oh, it really kicks up. And then I sit down and have a beer and then it goes away. The quality. So what is exactly what it was like, right? Was it sharp like a knife or was it dull, like a hammer, right? Or a mallet or find your own analogy. Radiation. Did it spread? Oh yeah, it starts up here, on the left part near my nipple, and then it like goes to my my breastbone. Oh, okay. Severity on a scale of 1 to 10. 10 being the worst pain in the world. What was it? Now remember, male patients, they're a little bit on the I don't know what's the best way. They don't have a high threshold of pain. Male patients, myself included, right? They'll exaggerate a little bit more. But female patients, especially those who've had children, they may under exaggerate it because childbirth is ridiculously painful. On a scale of 1 to 10, I don't even want to guess. It's above the scale. So a patient who's already been through labor, they may downplay it. And then, last but not least, T for timing or temporal factors. Is there a time that it comes and goes, or when do you get it, or when does it go away? Which is kind of related with the P. Okay, so it's PQRST: palliative or provocative, quality, radiation, severity, and temporal factors. And these are P. This is the what do you call the acronym for the characteristics of pain? If you're asking about pain. Mirroring, we already talked about. Of course, focus on the patient. Remember I told you about that medical assistant who just kept on writing on her clipboard without making some eye contact, right? Actually, good clinicians don't even write anything down. They get the story first, then they mirror, and then they start writing stuff down. But again, you may not have that luxury of time, especially if you're in a place like like a patient first, where the pace might be a little, or an emergency room where the pace might be a little bit faster. Always try to clarify. Always kind of open-ended. Push the patient for more information if the story still is vague. And it goes. Another thing we use is reflection. You encourage the patient to say. He goes, "Hey, do you think that was a good idea, or how do you feel about that?" Very open-ended, where you try to have your patient look at their situation in a different light. For example, why is you're trying to help your patient lose weight? You could ask them, what do you think is your greatest factor on why you can't lose the weight? And then makes them reflect, right? Whether it's BS or not, whatever BS answer they have, if it's a BS answer, it could actually also give you an idea of why. Like I've had patients like, oh, I'm big boned, and they go, oh, and he goes, okay. He goes, where'd you hear that term, big boned? Well, my mom used to say I'm big boned, and she'd love me anyway. You see, like how they're using it as an excuse, and then you could use what? You could use that for and against your patient to get your patient to stick to the diet and stick to the plan. And that's actually our job, trying to make it goes. We're not curing anybody. We're just trying to get the patient to stick to the plan. And when that happens, good thing happens. Now, of course, no closed-ended. No. The only time you use yes and no questions is this thing called the review of systems, or your ROS. That's some textbooks say it's part of your physical. It's part of your history taking, but it's actually kind of the part of your physical examination. Now, what's the review of systems? The review of systems is if you've ever seen something like this in the doctor's office, and then that's the point where the MA or the nurse or the doctor asks you all these yes or no questions, and it goes from top to bottom. They ask you, have you ever had a rash? And they'll say, Ms. So-and-so, just answer me yes or no. Have you ever had any rash, any itching, any change in nails? No? Headaches, head injury? Now, they make you go through the whole list, or they give you this checklist in the doctor's office, and they make you check what have you been experiencing lately that is not related to the chief complaint. Now, the ROS, or the review of systems, that's the only time you use closed questions or yes or no questions. And when you go down here, because sometimes it might relate, like for example, there are some pretty interesting pathologies, like for example, Krukenberg tumor. I once diagnosed a Krukenberg tumor, and I'll tell you what a Krukenberg tumor is. It's a tumor that it's ovarian CA, or is it ovarian, or yeah, now I'm forgetting. Well, it's cancer in the genitourinary area that relates to gastric cancer or stomach cancer. Well, I had a patient who had, genitourinary symptoms, and upon ultrasound, I found a mass. Now, then I looked at the review of symptoms. She also had GI problems. And then then we looked at her stomach and her intestines. Guess what? Found another mass. And that's a Krukenberg tumor. It's a tumor that goes from your genitourinary area to your gastric area, because they share the same, blood vessels. So if I didn't do my ROS, I could have missed it. Okay. Now, challenging patient. Many times you will disagree. Many times you'll say, "Oh my God, this person's just out of kilter." Do not challenge your patient, especially if you are sensing some neuropsychiatric problem. Okay, because if you challenge a psychotic, 1 minute they're very, very friendly. The next minute they will turn on you and they will hurt you. And even in psychiatry, we have whole chapters on how to properly challenge your patient. So leave that to the psychiatrist, leave that to the MD. So if your patient is like, no, I really saw my mother. She's talking to me. She's right there. Don't say, I don't see her. Just say, oh, okay, I'm sorry, but I don't see her, but I see that you see something there, or you see your mother there. What is she saying? Do you see how I'm not really challenging my patient, even though I don't see her? I tell the patient, you try to empathize with my patient. I always tell this story about this guy in my ER. He was seeing dragons in the ceiling. Now, it was offending the charge nurse, who's telling me, Dr. Garais, can you do something about this patient? He keeps on wandering the waiting room and freaking everybody out because he keeps on looking at the ceiling and being scared of the ceiling. Well, guess what? I told her, just leave him alone. He's not really doing anything. How's this? I'm going to put him in another room, and you just leave him there so he won't bother anybody. Well, she didn't leave it alone, and she kept on saying to the patient, I don't see anything. I don't see anything. Until when? He got so scared, he assaulted her. He punched her in the face because he was like, oh, leave me alone. Because you keep on pushing the patient, keep on challenging the patient. Hey, you're sick. You're not really seeing those dragons. Remember, to a psychotic patient, OSIS, abnormal condition of the psyche, which is their mind. Your mind can play tricks on you, severe tricks on you, especially if you're sick. So be careful. Try not challenging the patient. Always apologize. Always say sorry. It's not beneath you. It's part of your training, and it's a way to keep your patient calm, because you don't know who's a psychotic. You don't know who's on antipsychotic meds. Even people who have a lot of training forget this, and they call out patients, and bad happening. Probing. Now, you can probe and you can pry a little bit, but no, watch the nonverbal and verbal cues from your patient. Watch out, because pushing too much, that's probing. Okay, if they don't want to talk about something, then you write on the chart. It goes, patient was asked this question, patient denies any answer. It's the best way. And of course, don't agree or disagree with your patient. Okay. I called out one of my wife's colleagues the other day because she kept on saying, and again, it's recorded, she kept on saying to the patient, yeah, the doctor should have done that. Even though if the doctor should have done that, don't do that. Have you ever been to like a restaurant or a place of business where the subordinates always badmouth the manager, even though the manager probably deserved it, right? How does that reflect upon the customers or your patient? It's going to reflect poorly, and then you're going to have trust issues. How many times I don't go to these places where I've seen a poor team environment? I don't want to go there, right? So I go someplace else, and the same can actually happen, and does actually happen to offices. So be careful of that, right? Be diplomatic. I think that's the best way to look at that. Okay. Sensitive topics, respect. Another little story that I have, like you have military personnel, like for example, my uncle, he's in his late 70s, early 80s. He's an Army guy. Um, I never understood it being a Marine. Why do I still have to call him Lieutenant Colonel? You're not in the Army anymore, but it's part of his respect. So, I gave it to him, and you should, and he earned the title, right? And it's the same thing with doctors and nurses. Give them the title; they earned it. But and beware of it, like because I remember I came in, I saw a geriatric patient, and I came in and goes, "Good morning, sir," and he was like, "That's Master Sergeant to you," and I go, "I Master Sergeant," and then you just uh, depending on their lifestyle and other items, right? Be sensitive about things, okay, and be respectful. Depression, role as an observer. Remember, these things you cannot diagnose, but as a medical professional, you may see things. How many times, we used to call medical assistants and LPNs. Many people might even say, "Oh, they're a low person on the medical totem pole." No, they are not. They are part of the team. And how many times did the medical assistant see something that the MD didn't, because they're more exposed to my patient. And many times the patient doesn't want to show these things to the clinician, but they'll definitely show it to the person that's at the front desk. So if you see any of these little things, of course, make a note of it, inform your chain of command, right? Like how many times I was suspecting drug abuse on one of my patients. It was, you know who told me about the drug abuse? It was sanitation, the cleaning crew. They even whispered to me, Dr. Garais, she's always in the bathroom with her little bag. And then we found out what was in the little bag. She was on heroin, and she was taking heroin as we were treating her in the hospital. Because addiction is not only a physical thing, it's a mental thing. If me in my youth, I used to have no love for. I used to call everyone a crackhead. Especially my training was in the 90s, so everyone was either HIV or crack cocaine or alcoholism, and it was hard because you want to help people, but they're acting really crazy, and but and you don't. I'm not an addict, so I don't understand it, but then you have some empathy, and you have to feel for them, and this is how you understand addicts. Just imagine if I took away food and water from you. What would you do for me or for me if I did that for an extended period of time? Do you think you're going to have altered sensorium? Do you think you're going to have all of these things? Yeah, and you might see it. Do you think I'm going to be like the nicest person in the world? Yeah, I'm going to be the nicest, most charismatic person because and what does a substance abuse person look like? They look like you and me, and they come from all backgrounds. All right. I love the way the media makes addicts look like your typical homeless vet. Nope. Most typical addicts look and act just like you and me, just like the person in the mirror. So be careful, because they also can turn on you, and they do very, very interesting things to get what they want. Okay. And like I said, if you want to you want to understand addiction, take away food and water from you for a little while, and you'll do anything and everything. I remember when I was a kid, um, a friend of mine, he wasn't homosexual, but he started becoming a male prostitute. And then we were like, oh man, he's crazy. Oh, maybe he's secretly gay. No, he's not secretly gay. He's just so addicted to that cocaine that he'll do anything. And they do anything. and hurting you could be part of that plan. So be careful, keep your eyes open, head on a swivel, and again, be understanding and know who you're dealing with. Again, same thing with abuse, right? You could see it in women, children, and men, but women, children, elderly, because abusers pick their targets. But you can also see it in men. Okay, male rape is also, because if you're in an urban environment, it's also common. It's more common than you think. And partners will do things to each other for love, and there are also other people who will do things to each other for money. So be careful. Now, I don't need, this is not too important. You'll go over this table and other tables like it regarding substance abuse in your pharmacology. Uh, but, you add it to the things. And also, if there's there's a lot of open seminars, especially in urban places like the Washington, D.C., look out for them. And join them. Or if some of them have a small nominal fee of like $40 or $50, for updates for nurses and LPNs, take it, because this stuff changes all the time, right? There are things that people are abused now that blow my mind now. I don't understand it. I barely understood it before when I was in training, but now, whoo, some really interesting things, right? And also know the street names of things, and so that when you take a history, you can understand. I had a colleague of mine, Dr. Dimitri. He is from the Ukraine, and he did not grow up here in the United States. So it was very funny. One day, my attending goes, "Hey, look at Dimitri's chart. It's pretty messed up." And I go, "Why?" Look at the social history. Now, social history is when, like anything you do at a party, like drinking, sex, or drugs, right? It's one of the hardest things you can ask a patient. Like, "Oh, do you do illicit drugs?" Well, Dimitri put down on his social history for one of my known patients who was an addict. He put down he has a penchant for billiards. He goes, and cold drinks. And me and the attending, of course, were like, "What? That's not right." So, of course, I had to re-interview the patient. I can laugh about it now. It's 15 years ago. But the patient said to Dr. Dimitri is this. "Oh yeah," I goes, "I used to do ice, and every once in a while when I don't feel good, I do an 8-ball or two." So he thought 8-ball was billiards, ice was just cold drinks. Ice is methamphetamines, and 8-ball, I believe, is cocaine with a heroin chaser or something like that, right? It's like one of those mixed cocaine and something else, right? And I was giggling, but you could now see how cultural differences are very difficult. By the way, Dimitri left our ward, went to neurology. Internal medicine wasn't for him, and he was brilliant. He was like one of those Doogie Howser kids in the Ukraine. One of those people who skip high school and go straight to medical school, that kind of thing. But again, remember, there's different kinds of smarts, right? And a good clinician has to have people smarts, has to have a little bit of street smarts. So if you have a lot of that going on for you, because that with your academic stuff, you put it together, you'd be a dang good clinician. So 6 C's of charting. We mentioned on the chief complaint, it has to be in the client or the patient's words. Many places, especially psychiatric facilities or drug facilities, call patients clients. Clarity, you have to be clear exactly what was said. Completeness, did you get the whole story? Did you get it? Conciseness. Now, concise means the truth, but nothing but the truth within the space allotted. Now, what does that mean? Like, for example, if I'm interviewing a patient about depression, that's her chief complaint, depression. I want to only know the history of present illness, the depression, what triggered this depression, the one that's messing her up now or messing him up now. But typically in psychiatry, when you're giving an interview like that, they always say stuff like, "It all started when I was 6 years old." And you're like, "Oh, heavens. No. Ma'am, you're 42 now. I need to know what happened this month or the last couple of months." And respectfully, you ask them, and you have to be concise. And And when you're speaking to the doctor or you're speaking to the nurse or NP, be concise. Try to be able to summarize big stories and get it down into the a couple of sentences. Chronological order. It's always from the back to the front. So everything that's in the front of the chart or on the top of the chart should be the most recent. And when you turn the pages of a real chart, or if you move down, scroll down on an electronic chart, the most recent should be up top, and the past should be deeper. Of course, HIPAA, confidentiality. So those are the 6 C's. And I'm telling you, whether you take the CCMA, RMA, you're definitely going to have a 6 C's of charting, and you're definitely going to have 1 or 2 questions of how do you interview the patient, okay? So this is an example right here of an EMR, or an electronic medical record. And you could see it has tabs. And actually, I'm trying to get my wife to be a special guest lecturer for us. I want her to show you guys how her EMR system works. Of course, we're going to take a non-patient or a practice patient, and then we're going to show you the tabs. Maybe I'll because she's kind of busy, and also she's a little bit, regarding interviewing patients and speaking to doctors, she's really cool with it. But I don't know, she has a hang up of speaking to my students, but she's done it before, and I'm going to try to have her talk about some of these little things, and also to maybe show you guys how Epic, if maybe some of you are familiar with it, how administrators and clinicians utilize Epic, which is their electronic medical record. Now, the cool thing about EMR is that if I open something in EMR with my key fob or my security card, it logs in as me. So any changes will be me. That's why if you have a key fob or you have a security code, do not share it with somebody, because you will be liable with anything that they do in your name. Here's some lab results, right? This is what is this? Looks like a CBC. Right? You have your red blood count, hemoglobin, hematocrit, your MCV, MCH, and MCHC. These are your red blood cell indices, platelets. So these look like, and this is your differential, all the different white blood cells. So this is a CBC. Oh, here it is. Complete blood count. This is a CBC, and also they should have mentioned with diff or differential, which is all your different things here. And I'm looking at some results, lower limit, upper limit, and these are units, of course. Let's see. Looks like it's pretty normal. Yeah. And also in real life, the abnormals will be highlighted in pink or red. Okay. Okay, here's another one. Same thing with labs. Do you see the abnormals? And in many places, if the lab report doesn't highlight the abnormals, get if you have a paper that you're giving to your physician, get a ruler and a highlighter and highlight all the abnormals. Okay, and if you have a paper chart, you stick this top part out, right? So that the doctor sees that, hey, I've got to look at the chart. Hey, like, I have to do this. But nowadays, it's electronic medical records. You flag this, and it usually has this little red flag that your doctor sees when they open up their stuff. Again, SOAP. Here's an example of SOAP notes. Your subjective, a little bit of the history. Objective, what did we see on the physical examination that includes your vital signs? See this blood pressure, temperature, a little bit high. Abdominal exam revealed, rebound tenderness. Now, rebound tenderness is when you press on one side, like on the left side, and then when you let go, the right side hurts. And that's one of the big signs for AP, also known as appendicitis. So we have to admit, and then appendectomy would be scheduled that day. Okay. And how old is the patient? Well, if the patient was young, I'd have to also call pediatrics. These odds are, typical AP patient is usually from the age of 12 to 18 and usually female. Okay, so that's your subjective, objective, assessment, and plan. And that's how SOAP notes work. Now, you've went through all the medical abbreviations, and medical abbreviations, they're always used, but be careful because some people don't use it, but if you're using electronic medical records, if I write CXR, the electronic medical record will change it to chest X-ray, and then it'll take the step further. They'll ask you views, number of views, AP, and I click on AP, it'll be anterior posterior. If I click on PA, it would be posterior anterior. If I click on lat, it'll be lateral. And then so be careful when you use medical abbreviations, because sometimes it's not all that common. These are very, very common. SOB is shortness of breath, also known as dyspnea. So it doesn't mean your patient was being an SOB. I've gotten into trouble with that a couple of times. ROM, range of motion. Oh, let's talk about rule outs. Remember we talked about diagnosis? Let's talk about diagnosis. It's a state of condition, right, of complete or thorough knowledge. Now, prognosis, state or condition of before knowledge. Okay, so if I have diagnosis of cancer, your prognosis is, I'm looking into my crystal ball with the medical knowledge that I have and I have at my fingertips. How long are you going to live? How are you going to live in the next couple of years? Now, I'm looking at before knowledge. So that's why I don't buy when people tell me, oh, the doctor said my mom would never walk again. Or the doctor said my mom was going to die and she lived. Well, I don't have a crystal ball. I go by what? And a good clinician would say, let's say, for example, you have pancreatic cancer. You have 6 months to live. That's what the textbook says. When you're diagnosed with pancreatic CA and you have positive symptoms, you pretty much have 4 to 6 months to live. That's what the textbook says. But you tell your patient, hey, the prognosis isn't that good. It goes, the textbook says that most patients die within 4 to 6 months. But you know what? Let's work on our plan on what we're going to do to try to see how long we could extend that. Don't you think that's a better way to say it? But many times, especially when the patient's distraught and upset, because wouldn't you be upset if someone told you got 4 months to live? That's all they hear. Okay, so be careful of that. Now, what's this rule out? Rule out is your DDX, also known as your differential diagnosis. Okay, RO means rule out. Now, these are not diagnoses. Let me put that in red, because they are not diagnoses. This is how a differential diagnosis works. Let's say, for example, remember we talked about that 14-year-old girl who just had appendicitis? She's presenting with left rebound tenderness, right upper quadrant pain, and a mild fever. Well, when she comes into the emergency room, I'm thinking of 6 other things that could be the diagnosis. So I have to differentiate them or rule them out. So for that particular patient, I have to rule out some things. And one of the things I'm going to rule out is pregnancy. How many times I've had AP 14, 15-year-old female in an urban environment, right? She claimed that she's a virgin. She was definitely not. And what looked like appendicitis was what? Pregnancy, torsion of the uterus, or uterine cancer, ovarian cancer. It could be all these other things. Right upper quadrant pain with fever presents with all these other things. And those are rule outs. Those are differential diagnoses. You cannot code for these. This just shows the job of the clinician, the job of the NB, ND, and the NP to rule those things out. The diagnosis is the state and condition of complete or thorough knowledge. She has appendicitis. We definitely know this. I did an ultrasound on her. She has a positive McBurney's point with left rebound tenderness. It's what? It's appendicitis. But I had to make sure that I ruled out all the other things. And that's the thing that the parents don't understand, or family members don't understand. Like, what's taking so long? She needs a surgeon. Doesn't understand that I'm trying to, because that I'm doing my job and I'm trying to rule out and clear these differential diagnoses. Because like I said, how many times it looked and acted like appendicitis, and then I do my ultrasound, I don't find appendicitis, but what do I find? I find an ovum, or I find baby, I find all these different and lovely and interesting things. So we went through PQRST. So now you know what a rule out is, and differential diagnosis. So be careful, because, and that's the reason why we don't discuss diagnoses with the patient, because they could actually think that the differential is real. How many times I had patients back in the day when we had real charts, I had a patient think they read something and saw the word diagnosis next to it and thought that it was what? It was real. More abbreviations, and remember, this is do not use. Actually, JCO, which is the Joint Commission, also known as the Joint Commission. Actually, JCO means Joint Commission on Hospital Accreditation or Association, Hospital Operations Association, or something like that. But everyone just calls it the Joint Commission. They're the people who inspect hospitals and other medical facilities to make sure we're doing what we're doing and we're doing it correctly. And one of the things they do not like is abbreviations, because many times they're unclear. But just be careful. And like I said, what will the electronic medical record do? It'll change it for you. Actually, best bet, just write everything out and make sure your spelling is immaculate. We talked about PQRST. Here's a lovely, you could pause the video. We already talked about that. Personal data is all sometimes they call it demographics. That's all the date of birth, are they married, where they live, is all the basic data before we get the chief complaint, history of present illness. Now the PMH, your past medical history, that's anything medical, okay? And what specific question is, you ask the patient, what have you ever, it goes, have you ever been hospitalized? It goes, what were the medications, if you recall, in the last 10 years? That's what we always ask. And sometimes people have been put in other places other than a hospital. Family history. Now, family history, you're only dealing with immediate family members. Brother, sister, mom, and dad. I don't care about grandma, grandpa, nor don't care about your uncles, because I'm looking for direct genetic influences. Social and occupational history, that's easy. Remember we talked about social history? That's anything you do at a really, really bad party. So that's drugs, alcohol, and sex. Okay? Now at the end, you see these procedures. Read over them because they're nice. And look at this. How to deal with a potentially violent patient or a psychotic patient. Hey, it looks like a cute little boy, right? Oh, I hate pediatrics. There's a massive potential of violence to the clinician in the Department of Pediatrics, right? And progress notes, and read through some of these procedures. Some of them is a little bit dated, but remember, all the rules and regulations in the hospital are there for a reason. So let's now look at, and then we could call it a day because we're at the end of our hour. So let's look at, this is topic 3, this is week 3. So what's due today, of course? Did you do your quiz? And of course, homework. If you did that already, that should be good for the week. And now you got homework 3 and discussion 3. And here's an example of a medical history form that you could also practice with. Okay, and that's all we got. And it's like a little bit continuation of last week. And if there's any questions, comments, or recipes, all right, say now or forever hold your peace, because that is the end of this session. And please don't forget your discussions. Some of you, you'll notice that your discussions were a little bit late, but you know me, I'm a sweetheart. I'll give you a couple of days, right? But please, 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 you can see how all of this is gonna catch up to you if you don't make it like a weekly thing. So is there any other questions or comments, ladies? Ms.
No.
Carrillo? No, we're good? All right.
Yes.
Make sure to catch up. And also, if you're having some difficulty catching up, I've been giving out these really quick Zoom sessions just like this, 15, 20 minutes, just to give you guys the skinny, and not only for this class, but any other medical class. And I always like to remind my students, hey, I don't get paid by the hour. So if it's like, has to be at night or on the weekends, I'm cool with it. You know, well, I'm all at home anyway. I'm not going anywhere. So if there's something that you need to catch up on, or you're interested in maybe some extra credit, give me a call, shoot me an email, so we can provide those things for you. All right, ladies, if nothing else, let us